Good afternoon. Today's Grand Round speaker is one of us, Marie Robert. Marie Robert graduated from the University of Michigan with honors in psychology and neuroscience, and then went to medical school at University of Michigan. During her schooling, Marie spent several summers doing research on peptic ulcer and also on carcinogenesis at NIH. Marie spent a year as international scholar in Lausanne, Switzerland, where she studied French literature. And this will all tie back to what Marie is talking about today because it shows it was a very important step in developing humanities in our profession. Marie then moved from Michigan to California to do a pathology residency at UCLA, which in those days was 5 years, becoming chief resident and then GI fellow. And then, of course, UCLA recruited Marie as assistant professor. But then at Yale, the GI pathology team of Dr. West and Dr. Crawford recruited Marie in 1994 as assistant professor. Marie soon became the director of GI and liver pathology by 2000 and also the program director of the GI Pathology Fellowship. She rose through the ranks, becoming a full professor in 2007. Marie has a secondary appointment in medicine, digestive diseases. Marie has been nominated for teaching awards at Yale by the medical students and also the clinical fellows in GI. She is a nationally and internationally well-known speaker and lecturer. She is frequently invited to speak on GI pathology. She's been a panel member at national and international meetings, moderating these sessions. Marie was the president of the Roger Haggett GI Pathology Society, which is a companion society of the United States and Canadian Academy of Pathology, one of the largest bodies of pathologists in the world. So Marie's work is in the field of autoimmune GI tract disorders, most importantly celiac disease, and Marie is going to be talking about beyond celiac disease. She is the chief scientific officer of Beyond Celiac Foundation, also the chair of the Scientific Advisory Council at the foundation. Marie has carried her advocacy and her education through various podcasts, radio talks, web-based platforms, and even through Facebook platforms to the patients, to their families, and to the community, in addition to authoring several book chapters and invited reviews. So her teaching goes beyond teaching peer residents and pathologists, and it extends to the community as well. She has given her time generously and very kindly by visiting and speaking with community college students. Marie's pro bono work extends to digital pathology. She is a digital GI consultant for a small hospital in Tanzania, Kilimanjaro Christian Medical College, which is about 300 miles inland from the capital, Dar es Salaam, on the slopes of the Kilimanjaro mountain. And Marie recruited several of us, including me and Mina Shu and Zhenging Pan and others, to become digital pathology consultants for this small hospital. within our own institution, Marie has been a big supporter of women in medicine, chairing the Status of Women in Medicine group. So with that short introduction, I'm going to invite Marie to talk about her work.
Thank you. Thank you, Manju. She does the best introductions. And I asked her if she could be here today. So, well, it's always an honor to speak to one's own institution, and I really thank you all for finding the time to be here today. Today I'd like to tell the story of celiac disease, at least the part of the story that I know. And I think when we talk about autoimmunity today, we immediately talk about the environment in which it's occurring. So autoimmunity can be defined as a system of immune responses of an organism against its own healthy cells. And the environment is the complex of physical, chemical, and biotic factors that act upon the organism and ultimately determine its form and survival. Drilling down further on the environment of a disease like celiac, there's a biological environment that's dictated by genetics and the interface with other organisms, either symbiotic or pathologic. There are dietary, hygiene, and medication environments, and a lot of those are dictated by geographic and cultural differences, including things like patterns of antibiotic use. And finally, there's a societal environment. And by this I mean how society views the importance of the disease. What is the level of education and awareness? What are the rates and accuracy of diagnosis, the level of research funding, and what's available for medical and social support for the condition? When we think of autoimmune disease prevalence in the U.S. As physicians here at Yale, we are very actively involved with patients with IBD, rheumatoid arthritis, diabetes, multiple sclerosis, etc. And in fact, celiac disease prevalence is more than twice as much as any of these. When you look at NIH funding between gastrointestinal disorders, celiac disease, interestingly, always ranks last on the list. It's sort of the ignored cousin amongst inflammatory GI diseases, even compared to things like eosinophilic esophagitis. And we can think about why that is. Patients with celiac disease have sort of a normal lifespan. They're not arriving bleeding, needing surgery. And they also tend to want to blend in as people, as opposed to be loud advocates. So in the next few minutes, I'd like to give an overview of celiac disease, talk about the duodenal pathology at biopsy and in follow-up, including sharing some work that I and others are doing. I'd like to talk about clinical trials in celiac disease where there's really a lot happening. And then I'm going to pivot based on some recent experiences I've had and talk about something a little more unusual, the role of physicians can play in patient advocacy groups, and finally share my hopes for a celiac disease center at Yale. So what is celiac disease? It is a chronic immune-mediated enteropathy, that means small intestine, driven by dietary gluten found in wheat, barley, and rye. It's more common in women and presents at any age and in almost all ethnicities. It requires a genetic susceptibility, occurring almost exclusively in people with MHC class 2 HLA-DQ2 and 8 haplotypes on dendritic cells. There are other genetic factors, however, because only a fraction of the 40% of us who have expressed HLA-DQ2 and DQ8 ever develop celiac disease. And so far, there are more than 100 other non-HLA genetic associations. Over the past 15 years, the environmental factors involved in celiac disease have really gotten a lot of attention, and that is a fascinating story, including things like the amount of and the timing of introduction of gluten into the diet in susceptible kids in infancy, the microbiota, and usual childhood infections. Celiac disease is associated with a host of other autoimmune diseases. The one that is most commonly known is type 1 diabetes, which shares the same high-risk HLA phenotype, and that disease may also have viral and microbiome triggers. In addition, there's a link for 7 autoimmune diseases listed here, but having to do with where Epstein-Barr viral DNA binds to our own human genome. Considering the prevalence of disease, this map shows the seroprevalence of celiac disease across the world. And by seroprevalence, I'm talking about people with anti-tissue transglutaminase or endomysial antibody positivity. And you can see that in North America and South America, the prevalence is on the order of 1% or a little more, and it is higher in other areas. As an aside, I see that this is an unmarked map of the world. And so for you NPR listeners, if anyone ever locks you in a room, this is Ukraine. So that seropositivity translates into millions, almost 6 million people with celiac disease in North and Central America, South America, and the UK, Europe. What is the presentation of celiac disease? It is protean. It is a duodenal enteropathy, so we understand that there are gastrointestinal manifestations, but what is less well understood is that there are a host of extraintestinal manifestations, including CNS manifestations. Further, there are a number of people that, not a small population, who only have non-GI symptoms, and some people have no symptoms with celiac disease. So considering how to diagnose this disorder, the first thing to say is that a significant barrier to diagnosis is the ongoing insufficient awareness among medical professionals. Adults report an average delay of diagnosis of 10 years as they hop from doctor to doctor trying to understand their vague symptoms. Delays in children also occur. When we as physicians consider making the diagnosis, there are a battery of serologic and other tests to use, and they're quite good. The most frequently used today is the anti-tissue transglutaminase antibody test, and there are others. HLA typing may also be used, especially in equivocal cases, because if you don't have HLA DQ2 or DQ8, it's very unlikely you will ever develop celiac disease. Duodenal biopsies are a mainstay of diagnosis, for sure in adults and kids in this country. In Europe, the pediatric European groups have an algorithm that may allow one to omit biopsy if certain criteria are met. And monitoring response to a gluten-free diet is also an important component. So this is an interesting study talking about, getting back to our funding issues in celiac, the perceived treatment burden in a variety of diseases. And it's actually very high in patients trying to follow a gluten-free diet in celiac disease. Compared to IBD and diabetes, it's much higher. And it was surpassed only by end-stage renal disease patients on dialysis in this series. Now, why would that be? I've had the opportunity to speak to a number of people with celiac disease over the past couple of years, and these are the types of phrases that one hears. That basically you're walking around for your entire life with a cloud over your head. There's social anxiety and fear of eating, exclusion. It affects the entire family, and actually people make major life decisions based on the fact that they have celiac disease. For example, can I take this job, go to this college, go on this vacation, or move to this city? So they have mostly a normal lifespan with exceptions, but they describe it as, I've heard people describe it as a more limited life. Moving on to think about pathogenesis, celiac disease is the only autoimmune disorder where the trigger is known. And so that means we have a handle on some of this. Gluten turns on both the adaptive and the innate immune response. And in terms of the adaptive response, partially digested gluten gets in, is deamidated by tissue transglutaminase, and then is recognized by dendritic cells by binding to these class 2 molecules. And then it is presented to these gluten-specific CD4 positive helper cells that have a variety of actions. One, they stimulate the production of both anti-gluten and anti-transglutaminase antibodies. And two, they sort of set up a proliferation of a little army of CD4 positive cells that then release inflammatory mediators that change the environment, the milieu, to a highly inflammatory, predisposed environment. In terms of the innate immune response, gluten peptides and some other triggers, including enteric infections, lead to increased permeability of the epithelial barrier, and dendritic cells also release IL-15 and other mediators. And this results in the activation of intraepithelial lymphocytes, CD3, that are normally CD3 and CD8 positive, and they undergo the process of inducing apoptosis in epithelial cells. The epithelial cells themselves, also under stress, secrete IL-15, and all of this eventually affects the T regulatory cells as well to decrease their function and increasing the loss of oral tolerance. The role of microorganisms in celiac disease is really coming on with some fantastic work done by Elena Verdu and others. And this is a massive oversimplification. But basically, in vivo and in vitro studies, mostly of bacteria, support the association between gut microbiota and celiac disease. For example, the microbiota taxonomic composition differs between active celiac disease and patients who are either following the diet or normal controls. And this is true both in oral, duodenal, and fecal samples. Bacteria in the microbiome in the gut can modify immunogenic food antigens for better or worse. They use particles to produce metabolites that affect homeostasis, and they contribute to intestinal barrier dysfunction. In addition, common viral infections, so far we know for sure about rotavirus and reovirus, trigger an inflammatory response to gluten antigens by initiating Th1 responses over Treg responses. And this is associated with the development of symptomatic celiac disease in susceptible hosts. There's very elegant work on this in animals and in humans by Bana Jabri at the University of Chicago. So while quite a bit is known about celiac disease pathogenesis, there are some unanswered questions. For example, why is it that celiac disease can manifest at any age, even years after gluten is introduced into the diet? Further, why is it that only a fraction of people with DQ2, DQ8 get celiac disease? And this may have to do with how T-cell receptors are developed. The serology and biopsy-proven prevalence of celiac disease has increased in the Western world 2 to 4-fold over just a few decades. And the severity of clinical malabsorption does not correlate with the severity of mucosal damage seen on biopsy, which is very interesting to us. So with that, let's move on to discuss duodenal mucosal pathology and celiac disease. This is a biopsy from a normal person, floating and sailing and seen from a dissecting microscope. And you can see these beautiful villi extending upward, slender, like a sea anemone. This is the same preparation in a patient with untreated celiac disease. And it's very barren, sort of like the surface of the moon. Under the microscope, in the distal duodenum in health has slender, tall villi seen here, and the ratio of the villus height to the crypt depth is at least 3 to 1 or more in the distal duodenum. The epithelial cells, the absorptive cells, are very orderly, and there's only about 1 lymphocyte per 7 to 10 enterocytes. This is the lamina propria compartment and showing the normal component of immune cells. This is the same preparation in a patient with untreated celiac disease. So it's completely flat. There's no villi extending upwards. And the mucosal width is taken up entirely by hyperplastic crypts. And the lamina propria is full of all these immune cells. The epithelial layer looks pretty jumbled up, and it contains innumerable lymphocytes. Our job as pathologists is to score villus blunting, and we do this with a three-tiered scale, very simple, mild, moderate, or severe blunting, or we can use the Marsh classification system, and I mentioned Marsh because Michael Marsh was one of the key workers who worked in families and helped us understand that the effects of celiac disease happen well before any blunting occurs. There's a whole spectrum of pathology seen in patients and their at-risk family members. To the point where we now understand that the biopsy doesn't have to show blunting at all for a patient to be affected by celiac disease. So for example, here is a high-power view of just the tips of normal villi in a healthy person, orderly enterocytes and just a few lymphocytes here or there. And in this biopsy, the epithelial cells look very reactive and there are innumerable lymphocytes, but there's no villus blunting. And this patient has symptomatic celiac disease with increased TTG in the diagnostic range, antibodies, and iron deficiency anemia. Another caveat and wrinkle in how we make a diagnosis is that we've only realized probably in the past 15 years that celiac disease can be really patchy in its mucosal manifestation. This is a series of biopsies from a child with Down syndrome, and all four biopsies from throughout the duodenum, the bulb and the second duodenum, were put together in one jar, and that's fine to do. So you can see here, this biopsy has very tall villi. I hope you can see that even at this low magnification, and in fact it's entirely normal. Whereas these biopsies, these two have these pale mucinous glands, and this tells us these are Brunner glands. This tells us that the biopsy is actually taken from the duodenal bulb, the first part of the duodenum. And there are no villi sticking out here, even though this is sideways, you can see that. And you flip it around on higher power, it's a completely flat mucosa with increased intraepithelial lymphocytes. So in this child, the bulb is the only place showing the typical mucosal changes of celiac disease. And if you don't biopsy the bulb, then you might miss the fact that there's any injury at all. So this has resulted, this realization, which has now been shown in a variety of pediatric studies series and even adult series, has changed the practice guidelines for gastroenterologists, who are now told specifically do biopsy the duodenal bulb and second duodenum. Back in the day, pathologists actually asked them to exclude the duodenum for reasons I won't go into. And finally, in considering diagnosis, pathologists know very well that there's a whole bunch of things that lead to inflammation in the small intestine, including leading to increased intraepithelial lymphocytes and leading to villus blunting. For example, in our practice, the most common reason to have increased intraepithelial lymphocytes in the duodenum is Helicobacter pylori gastritis. In terms of villus blunting or IELs, I always like to point out that drugs are forming medications, an ever-expanding list of things that can impact the small intestine with inflammation. I'll just give a shout out to two. One is olmesartan, that until recently was a very commonly used blood pressure medication, angiotensin II receptor antagonist. And olmesartan and all its cousins, with the word sartan at the end, can lead to a completely flat mucosa. It's a very interesting story how this was figured out, but patients were very sick and being treated with very serious medications until they understood it. Checkpoint inhibitors are also very well known to cause an enterocolitis that can lead to a sprue-like picture. And I'll give an example of that here. So here we have, again, normal villus architecture with villi going up. And this is one of our patients with melanoma treated with ipilimumab, who developed a flat biopsy. And this looks, for all the world, like untreated celiac disease. Now, obviously, we know who this patient is. They're being treated, and there's not going to be confusion. And in fact, as an adverse immune response, enterocolitis is one of the most well-known and most common in checkpoint inhibitor therapy. However, it gets a little more interesting for celiac disease because there's at least one case report of a patient who went on from their ipilimumab therapy to unmask their latent celiac disease, and they now require a gluten-free diet for the rest of their life based on this insult. In considering some of these nuances and changes in how to make the diagnosis of celiac disease that include biopsy, I was approached by Joe Murray, who's one of the sort of synonymous with celiac disease worldwide, one of the most important workers at Mayo Clinic, who approached us at the GI Path Society to put together a best practices document, a joint effort to how to handle the biopsy in celiac disease. And this was great because while there have been plenty of guidelines for clinicians, there really hasn't been anything for pathologists to use to help us understand what we can do better. And so this wonderful group of collaborators put together a document and published it. And I think just a couple things that I'll pull out for the pathologist in the room is that the evaluation of villi, we have to be very vigilant about this, and it must occur in very well-oriented sections. And I think it's incumbent upon us to do serial sections very routinely in order to achieve those well-oriented sections. If we don't, we risk overcalling blunting in what is actually normal. Likewise, intraepithelial lymphocyte quantity should be evaluated, especially in mucosa with normal villus height, and determined to be either within normal limits or increased. And we have ways of doing that in a semi-quantitative fashion if need be. So there's a lot of agreement about how to diagnose celiac disease using a variety of serological, genetic tests, symptomatology, and biopsy. But there's far less agreement on how to follow patients with celiac disease who I mentioned feel a significant burden of disease following the gluten-free diet. In fact, what is done for celiac disease patients, in adults, they will tell you that the follow-up often consists of diagnose and adios. They're sort of on their own. They get an initial consult with a dietitian, and then depending on the practice patterns of their primary care person or gastroenterologist, they may or may not be seen after the first year of follow-up. And in fact, there is no requirement of follow-up biopsy to confirm that the mucosa has returned to normal, and the duodenal biopsy is certainly a snapshot of ongoing injury due to gluten. Further, 10 to 30% of celiac patients attempting to follow the diet well have persistent symptoms despite their good faith effort. And we know that ongoing mucosal injury is associated with chronic nutritional deficiencies, the development of osteoporosis, and lymphoma. So Dan Leffler, who's a wonderful colleague at Beth Israel Deaconess and another key worker in the field, and I began a discussion about trying to understand how we could look at this problem. And we asked the question, are symptom profile, gluten-free diet adherence, follow-up tissue transglutaminase, antibody titers, or any other work surrogates for mucosal healing? And this premise, although it's used in practice, has never really been tested across celiac disease populations. Although there's a hint from clinical trials that mucosal injury persists in some patients that they thought in the trial should not, based on symptoms, TTG should not have had any injury. So I reached out to 14 colleagues in the US and Europe to put together a cohort to try and get a hint of this question. And our aims were to define factors associated with mucosal healing or persistent villus blunting in a multinational cohort, and hopefully to stratify populations who might benefit from adjunctive therapies that are currently under development. And this title of our presentation sort of sums it up, is that these data do not predict duodenal mucosal healing in follow-up biopsies from celiac patients, and we were both disappointed and surprised by this. Just a little detail about the study. We had 239 patients with two biopsies at 2 time points, and 184 had a biopsy interval of greater than a year, which is what you want to give the diet a chance to really work. Interestingly, 78% of them reported following a strict gluten-free diet, while 19% reported partial, and a few not at all. And so just to summarize some of our results from that study, and it's a very busy table, we're just going to look at a few points. So at time point 2, considering just the distal duodenum and the Marsh score or villus blunting, there were 130 patients whose Marsh scores improved at the second time point. And yet, even though it was improved, 43% of these patients still had classic celiac disease symptoms, and including things like 25% of them had abdominal pain. And further, even though their biopsy looked better, their tissue transglutaminase antibody in 28% of them did not decrease. Antibody levels should go down if you're successfully following the diet and your mucosa looks better. So mucosa better, but still some problems. On the other side, in 40 patients, the biopsy, morphology, and villus blunting did not improve. And yet, 38% of those patients went from having classic symptoms to having no symptoms, and the titer actually did go down, even though they're in 33%, even though their biopsy did not improve. So this was confusing to us, but I think it was a sort of a red flag and a wake-up call. So we're still analyzing these data, but the initial take-home points are that duodenal mucosal injury persists in a significant subset of celiac disease patients adhering to a strict gluten-free diet. And symptom improvement and decreasing titers are not reliable indicators across the board of normalization of duodenal histology in celiac disease. So we think these findings support the need for greater monitoring of mucosal healing in celiac disease and for the development of disease activity monitoring methods that are less dependent on things like patient-reported symptoms. So I really can't talk about celiac disease without spending a few minutes talking about refractory celiac disease. And this is defined as persistent or recurrent malabsorptive symptoms with villus atrophy despite strict gluten-free diet adherence for more than 12 months and in the absence of other causes of villus atrophy. In considering so-called apparent refractoriness, this is a very important graph to understand. So for all comers who come and say, I'm still not feeling well, this isn't going too well, of those 10, let's say 10%, only 10% of that group actually will turn out to have bona fide refractory celiac disease. The rest of folks who initially aren't doing well have a host of other things, the most common of being unintentional gluten exposure. They could have microscopic colitis or a variety of other things. Refractory sprue is an interesting topic, and it's thought in terms of pathophysiology. The most global thing to say is that there is evidence that unremitting IL-15 production is the cause, one of the big causes of the ongoing inflammation in refractory disease. So for the patients who really have refractory celiac disease, who have been shown they don't have something else as a cause for their symptoms and their flat mucosa, there are two categories to know about. And these categories have been defined, it's important to say this, at referral centers for celiac disease, of which there's only 7 or so in the world. So patients go through a number of hoops before they're really diagnosed with refractory disease, and then they may or may not be sent for a clinical trial or to have confirmation at one of these centers. And then looking at that subset of patients, that rarefied group, RCD 1 and 2 are defined as follows by pathology and clinical features. Patients with RCD1 have normal phenotypes of intraepithelial lymphocytes, do not have clonal gene rearrangements by molecular methods, and tend to respond pretty well to incremental clinical therapies such as a course of budesonide, etc. And they have a very low rate of developing enteropathy-associated T-cell lymphoma. Whereas by definition, patients with RCD type 2 do have abnormal intraepithelial lymphocytes, immunophenotype, either by immunohistochemistry or flow cytometry. They lose CD8 and acquire certain NK receptors. And also, they do have monoclonal T-cell populations by molecular methods. Their response to clinical therapy is variable, and many do not respond and need really big guns, cladribine and other chemotherapeutic regimens. And they have a frequent risk of developing T-cell lymphoma. So using those criteria, the prognosis by refractory disease classification really sorts these patients out well. RCD type 1 patients hopefully have a normal lifespan, but RCD2 patients have a much diminished lifespan, and patients with lymphoma do even more poorly. So the reason I'm bringing this up is that as these published guidelines became more and more read and understood, we ran into a problem here at Yale that prompted I and my colleagues to do a study to understand this. So there was a marked increase in requests from our clinicians to do clonal analysis and follow-up biopsies of symptomatic patients who were coming in and saying, hey, I'm not feeling well. And what was going on is that the first thing that was done was endoscopy and biopsy to get the status of inflammation, and then we were immediately being asked to act on those biopsies in paraffin to do this very sensitive assay. And we found that more than 60% had monoclonal T-cell populations using PCR on paraffin-embedded tissue. However, there was no correlation of that finding of clonality with the degree of villus blunting. And further, most of the patients were not that sick in the first place, and they responded to having their diet tweaked and going back to the dietitian. They in no way had RCD, even type 1, let alone type 2, which is what this is supposed to mean. So we were really concerning people. We were giving bad news, saying you have a clone, you're going to get lymphoma, and this was a very unsatisfying experience. And it prompted us to try and do some work on this. So with the help of several people in the department, including Pei Wei Ramchelli, who was our fellow at the time, we looked at the incidence of monoclonal T cell receptors in gene rearrangements, and that is in duodenal inflammation from all comers, from RCD, responsive celiac disease patients who are just getting a second biopsy, and first presenters with celiac, and one non-celiac population. And here's what we found. This is Helicobacter pylori associated inflammation, celiac disease patients at follow-up, none of whom met criteria for RCD, newly diagnosed celiac, and then RCD2, when we're expecting it, and RCD1. So the only category of patients who, by the literature, we're expecting to find clones in is RCD2 patients. And in fact, we found clonal populations in all of these patients, including Helicobacter pylori duodenitis. And so pathologists are not too surprised by this because we know that this is a very sensitive assay, talking about very small pieces of tissue, and this is just an inflammatory clone. It's not a malignant clone. And so the message we're putting out, or we did publish, was that clonal T cell populations in this setting are clinically insignificant unless the patient meets other bona fide criteria of RCD. And this really had not been previously discussed, and I hope that this will lead to a paradigm shift in practice such that we need to all resist the urge of submitting small biopsies for PCR analysis in this particular setting until the much more common causes of apparent refractory disease are excluded. That's not to say that the biopsy is not useful in RCD. In fact, it's very useful. So this is some work done with Fred Weinstein at UCLA, who was following 10 patients with refractory celiac disease. And that's a lot of patients to have in your solo practice because it's such a rare condition. And in fact, patients with refractory celiac disease have differences in their mucosal appearance compared to patients with responsive celiac disease at initial diagnosis. We found that all patients had subcryptal lymphocytic infiltrates, which to the GI pathologists in the room, we know that that is like an IBD finding. That's what we see in ulcerative colitis in the colon. They have thin atrophic mucosa, and they often have collagenous sprue. So I'll just illustrate a few examples of this. So here we have a biopsy from a patient with new onset, newly diagnosed but responsive eventually celiac disease. And so the crypts are taking up the whole mucosa. There are no villi, but the crypt bases are landing right on the muscularis mucosa here. Whereas in refractory celiac disease, the lamina propria is expanded by inflammation to the point where the crypts are separated from the muscle coat by a space with inflammation. You're never going to see that in regular celiac disease. This biopsy shows two findings. Atrophy, very thin. Look how thin the mucosa is overall from the top to the base of the crypt. And there is abundant collagen deposition in the blue trichrome stain here. So I'm going to pivot now to talk about clinical trials in celiac disease because I'm hoping that someday that's what we're going to be doing around here. And there's really some very exciting stuff going on. There are 34 trials that have been completed and 9 or so that are ongoing. And this is a disease that's really poised for drug development. It's common. The gluten-free diet is inadequate. There's a need for lifelong therapy. The pathophysiology is well elucidated, and there's been a lot of progress in key areas that you need to do to get the FDA to approve your trial, like study design and outcome measures. So if we go back to this cartoon of pathogenesis, really at every step along the path, there's a potential to intervene. So there's a phase 2B trial now going on in lataglutenase, which breaks up gluten in the stomach into very small molecules, so it doesn't have that immunogenic effect. And another one entering, the first one to enter phase 3 is lirozitide acetate, which tightens up the tight junctions and helps permeability. We stole IL-15 from rheumatoid arthritis, and this has been used both anti-IL-15 antibodies, and this has been used both in refractory disease, and now it's entering a phase 2 for just symptomatic, persistently symptomatic, not refractory disease. And I'll go into a little more detail on what I think is very exciting is the concept of tolerance induction in celiac. So, immunogenic tolerance refers to antigen-specific inhibition of a very selective immune response, and this is sort of the holy grail that we hope will be the future for the treatment of autoimmune diseases and also allergy and even transplantation. And the goal is that you're essentially curing the disease by specifically targeting only the T cells that are active in that disease rather than a large-scale immunosuppression that puts the patients at risk for infection and neoplasia. And I'll just share one example. This is Steve Miller's very exciting work at the University of Chicago. He took nanoparticle technology, which is a well-known technique, and these innocuous compounds, he stuck a gliadin moiety onto it and infused it into patients by IV. Very important, not sub-Q, which gets to a certain dendritic cell that is more effector activating, but IV. And what he found is in this imbalance, what the hope is, and it's been shown in animals, the imbalance of regulatory to effector cells normalizes and restores homeostasis, and you hope that you won't react as much or maybe at all to gluten. And so they've had a very exciting result presented at the European GI meetings last fall in a phase 2A, that they met their primary study objective of preventing activation of interferon gamma producing gliadin-specific cells during a gluten challenge in these patients. And that was associated with some improvement in pathology on the biopsy and reduced circulating gut-homing CD4 and CD8 cells during the challenge. So they think that this is the first clinical trial to demonstrate induction of antigen-specific immune tolerance in an autoimmune disease. And hopefully that'll be proven to hold true in bigger trials and in other diseases. So I just want to spend the last couple of minutes pivoting to a little more outside the box topic, and that is due to the opportunity I had to be the chief scientific officer of a nonprofit foundation for celiac disease called Beyond Celiac. And that is to consider how physicians can participate in patient advocacy groups to impact a disease on a societal level. And the clinicians in the room are already aware well of how to do this and these opportunities and what that can mean. So Beyond Celiac is a nonprofit foundation dedicated to accelerating therapies and a cure for celiac disease. And in 2018, they decided to create a science department led by a CSO. And through a completely serendipitous series of events, I took on that consultancy role. And by the way, for faculty, Yale allows 1 day in 7, or sort of a 20%, for us to consult with other entities and try and be of use. And that's what I did. This was very exciting, something for pathologists that doesn't see patients. It's not the usual thing. And in that time, in the past, over that time between 2018 and now, I created a scientific advisory council. Together, we established a strategic science agenda, a granting program, and we engaged donors in our vision to give us money to create grants. I circulated internationally a request for applications and put together a study section style grant adjudication process. And I'm really proud to say that in 2019, we awarded $600,000 in basic science and translational research grants. So I hope that they will continue doing this. I just wanted to give a shout out to the Beyond Celiac SAC. I've already mentioned Steve Miller, Joe Murray, and Dan Leffler. Ed Liu is a pediatrician at Colorado. These are really a who's who in celiac disease. We also have immunologists and biologists. And finally, I don't know if anyone interfaces in the world of cystic fibrosis, but Bob Bell is really famous individual. He, for decades, was the president of the Cystic Fibrosis Foundation and is responsible for bringing it to what it is today, which is a multi-billion-dollar organization. And he's also responsible for creating the environment whereby drugs were developed such that now patients with cystic fibrosis live to adulthood. So I got to work with this individual, and that was fantastic. Our latest activity was I was asked to put together what we called a research summit. It was a workshop meeting where I created an agenda and goals. We brought together 50 stakeholders representing the groups you see here, and including insurers and the FDA. And our goals were to identify remaining barriers to getting therapies to market and to strategize solutions. Our outcome from this so far is we have a white paper in revision, and we'll be presenting these findings to multiple stakeholder groups and hope to follow through on the action items to get this moving along. And finally, this is my last slide. All of this, this experience, which I'm just very humbled and honored to have had, has led me to think a little bit bigger than what I think about at the microscope. And I think, so I've been having conversations, and some of you have been very generous in discussing with me the possibility of establishing a comprehensive celiac disease center at Yale. So what's going on at Yale, present and future? We have an excellent, outstanding pediatric celiac program, and Raffaella Marotti is a part of that. Anthony Porto is the director, and he has a multidisciplinary coordinated care program. Adult GI diseases, treats and works with celiac disease patients, as well as our large private practice group. But my vision, my hope, is the establishment of a truly comprehensive celiac disease center as part of the new digestive health service line, and to bring adult and pediatric services with follow-through of other disorders such as non-celiac gluten sensitivity. And I hope to recruit a nationally recognized leader. And I begin discussions to engage our world-class immunobiology and translational immunology programs to create a basic and transitional research into the environmental, the genetic, and the immunological disease mechanisms and exploit this knowledge for targets. And so I'm very, very grateful that people have been engaging in this, and anyone in the room, you're welcome to join in this conversation. Just email me. There's a lot happening. And so with that, I'm finishing. I'd like to acknowledge my early mentors in pathology training, Fred Weinstein, Klaus Lewin, my Beyond Celiac and international collaborators. I always have to acknowledge Mike Nathanson, who's been a mentor throughout my career. And I want to really thank Jordan and Kevin, Lauren, Gary, Anthony, and Leo for entering into this new discussion. Thank you very much for your attention.